ready? Okay, so Elizabeth, it's all yours, please.
Yes, thank you, Antonio. So welcome everybody and good afternoon. Thank you for attending this webinar on childhood onset Charcot Marie Tooth diseases organized by EURO-NMD in partnership with European Academy of Neurology and EURO-NMD for rare neurological diseases. Thank you to our today's speaker, Dr. Isabella Moroni, for honoring us with her presence and for presenting this topic. A little presentation about Dr. Isabella Moroni. She's currently working in the Fondation IRCCS Institute Neurologico Carlo Besta in Child Neurology Department of Pediatric Neurosciences in Milano, in Italy. Our main areas of clinical and research activity include the care of patients affected with rare genetic diseases of the peripheral and central nervous system, including neuromuscular and metabolic disorders. Today, so Isabella is going to provide an update overview on infantile onset form of Charcot Marie Tooth disease. So thank you again, Isabella, for your presence, and the floor is yours.
Thank you, Antonio and Elizabeth, very much for the introduction and the invitation. And thank you in advance to people attending the webinar. I really hope that would be of interest, in particular for youngest neurologists and child neurologists. The topics that I will address in this talk will be mainly from the clinical point of view. I am a clinician, a child neurologist, as you heard. And we regard the CMT definition and the classification, and also the peculiar challenges we face working with patients of pediatric age that include the diagnosis of the different CMT forms, his treatment, and the trial readiness. When talking on rare disorders, I think it's always important to give some historical notes remember how much work it took in past years to get the current knowledge. So the first description of patients affected with hereditary neuropathies date back at the end of the 19th century, with almost simultaneously publications from the leading scientists in this field, Charcot Marie Tooth, and also Desjardins and Sautat. They described the clinical neuropathological features of families with different inheritance patterns and disease onset. But since the identification of the disease, many pioneering neurologists have contributed to its classification and clinical definition, like Thomas, Dick, and Lambert, and the term hereditary and sensory neuropathy used in the 70s subdivided the various forms on the basis of neurophysiological features, namely HMSN1 for demyelinating, HMSN2 for axonal, 3 for the hypomyelinating, early onset, Desjardins, and so on. The term HMSN has been more recently substituted with the term Charcot Marie Tooth disease that groups a large and heterogeneous number of peripheral nerve disorders, where the neuropathy is the sole or predominant manifestation. And this is the most common hereditary neuromuscular disorders, with a prevalence up to 1 to 2,500. According to the common proposal, the classification now is based both on the electrophysiological features and on the mode of inheritance. The demyelinating when nerve conduction velocities are below 38 meters per second, termed CMT1. And axonal when conduction velocities are above 38, CMT2. Intermediate when velocities are between 25 and 45 meters per second, but exists also pure motor and pure sensory or sensory autonomic CMT called HMN, HSM. The inheritance pattern can be autosomal dominant, autosomal recessive, and X-linked. Of course, there are also sporadic forms and de novo forms. The typical signs and symptoms for the suspicion of a Charcot Marie Tooth disease are presence of asymmetrical distal weakness, sensory loss, mainly in lower limbs, the presence of foot deformities that progressing and worsening slowly over time, and with variable onset from infancy to adulthood. With the suspicion, clinician can address neurophysiological study that confirm the diagnosis showing symmetrical abnormalities of nerve conduction, leading then to start genetic studies. The diagnostic tools have extraordinarily changed over the last century, since they relied on analysis of pedigree or neuropathological features, while the identification of the first genetic defect in 1991 was the PMP22 gene duplication, and in subsequent years, as shown in this image, several point mutations in several other genes were identified with Sanger sequencing technique. But later, with the increasing use of next generation sequencing technologies, the discovery gene also in Charcot Marie Tooth disease has rapidly accelerated over the past 2 decades in particular. So over more than 120 genes have been identified to date. And the increasing number of genes has broadened the classification of CMT, incorporating the neurophysiological features and inheritance pattern and the mutated gene, as you can see in this slide, and highlighted the marked phenotype, genotype, heterogeneity. This is only a partial list of genes associated to demyelinating dominant and recessive CMT1 and CMT2, so axonal and dominant recessive form. But also another slide with the list of part of the genes with X-linked forms and pure motor or pure sensory form, but not to read, to be read, but just to give you the idea of the extreme complexity of the CMT classification. The genetic heterogeneity is also increasingly evident, like is shown in this picture from a nice paper from the UCL group in London, where in the colored boxes are depicted the CMT phenotypes, CMT1, 2, HMN, HSN. On the left, the dominant form, and in the right, the recessive and X-linked. And as you can see, there are mutations with the red arrows that are present in the same genes, can cause demyelinating or axonal CMT, or can be associated with the different modes of transmission, as in case of MPZ gene, for example, here can be associated with the CMT1 and also 2. So demyelinating or axonal, or like GDP1 gene 2 that can be associated with dominant and recessive forms, or also Hint1 and IGHMAP2 genes that can cause both axonal or pure motor HMN. And the large number of molecular defects underlies many different pathogenetic mechanisms of the disease, as illustrated in this image, like formation and maintenance of myelin, also mitochondrial dynamics and axonal transport or vesicle trafficking, and many others. So you can imagine the difficulty of predicting specific therapies for each different form of CMT. Although many of the forms of Charcot Marie Tooth disease result in similar clinical manifestation with muscle weakness and atrophy, foot deformities, as I have explained before, the rarer forms can be associated with the clinical peculiar features or involvement of other systems and organs, like is depicted in this nice cartoon. And particularly CMT in childhood age present with different signs and symptoms depicting more complex syndromes that have to be known and considered. Now, move on the pediatric world. The approach and the diagnosis and care of CMT in this age raises several challenges. We interface with patients of very different ages, from birth, infancy, also adolescents and young adults. So patients present also a early disability and show a severe progression. Moreover, there is in this age also a high genotype phenotype heterogeneity, and we face frequently with sporadic or apparently sporadic cases, and the rarity of several forms altogether make difficult to reach the definite diagnosis. This diagnosis, of course, is crucial to permit the familial appropriate counseling and offer a possible prenatal diagnosis. So we must always remember the importance of accurate anamnesis and deep clinical characterization that can help to address appropriate and rapid genetic tests, as I will show later. First, we must talk a little bit about the commonest form, CMT1A, that is the most frequent CMT also in pediatric age. The age of onset is variable, but more often the first signs are reported in schooler age. In most cases, limited in lower limbs. With parents reporting gait difficulties, frequent falls, sometimes foot deformities, usually first pes planus that subsequently evolve in cavus or cavuvarus, that can be also asymmetric, like in this image of one child. And this all cause inability to walk on wheel. The genetic defect of CMT1A is the well-known duplication of a short arm of chromosome 17 that includes the PMP22 gene that we can diagnose through an MLPA analysis. But it must be remembered that the different alterations of PMP22 gene determine other phenotypes. A deletion of the same region causes another inherited neuropathy, that is the hereditary neuropathy with pressure pulses, that is responsible for acute motor and or sensory deficits also occurring in childhood. And point mutations of PMP22 can cause different phenotypes, classical CMT1, but also congenital severe early onset neuropathy, and also HNPP. Coming back to CMT1A clinical features, in our experience, we noticed that in addition to lower limb distal size, in a certain number of cases, there is an early involvement also of distal upper limbs and causing limitations or fatigability in writing and in manual dexterity, like in this child that show impaired finger extension that progressed over the years. Moreover, in a significant percentage of cases, the index case is the proband, and there is a negative family history. So the diagnosis in the child can allow to identify other subjects in the family and address proper monitoring. About variability in CMT1A, usually the signs are mild, as I would like to show in this child. If the video move, yes, mute. He can walk on his toes, as you can see, and the foot deformity is very mild, but he cannot walk on his heel. And his sister, she's more impaired, as you can see, with foot deformities in cavo varus, and her gait is clumsy and slower, and she hardly can walk on toes, but she cannot walk on her heels, as you can see now. Then she stopped. Well, if CMT1A is the most frequent form, on the other hand, the frequency of the other forms is much more lower, as showed in this table from a multi-center study we published a few years ago that included a large series of patients aged under 20 years. Type 1 represents almost 50% of whole case series that define CMT, while CMT2A due to MFM2 mutations account only for 6% of the defined CMT. And this is also confirmed by our experience. We collected in past 20 years more than 300 patients, the majority of them with defined genetic forms. And between them, CMT1A accounts for about 60%, while mutation in other genes like GJB1, MFN2, and also GDP1 or MPZ are responsible for 5–6% of defined forms. And the other genetic CMT are very rare or identified only in single affected cases. Moving on these rarer forms, clinical features in congenital or early onset CMT are very different from what I just showed. Generally, the infant presents with diffuse marked hypotonia, distal weakness, frequently associated with skeletal deformities and like flat foot or hand joint limitations. Infants show a delay in motor development that cause subsequent disability, often severe. And moreover, there is often an involvement of cranial nerves and central nervous system. And in some cases, they develop swallowing and respiratory impairment. The more frequent early onset forms are the demyelinating or hypomyelinating with extremely slow nerve conduction, under 12, for example, meters second, and are mostly due to point mutations in the genes here listed, PMP22, MPZ, EGR2. Cause this girl is an example of severe walking disability. She's affected with a mutation in MPZ gene, and her walk is possible only on tiptoes due to precocious retractions of Achilles tendon. It is well known that in these genes, some peculiar clinical signs can be associated to the neuropathy, for example, pupillary abnormalities or sensory neural hearing loss or facial weakness with MPZ gene, or cranial neuropathies with EGR2 gene, and also facial weakness and mostly congenital onset glaucoma with MTMR genes. And the prominent sensory symptoms involvement is associated with periaxin defects. But in last years, there is an increasing evidence for other signs and symptoms associated with different pediatric CMT forms, such as cranial nerve involvement and ocular signs, early scoliosis, early hand weakness, and others. And I want again underline that these features must be known, searched, and recognized at onset and also during the follow-up, both to address targeted genetic tests, but also to interpret the results from NGS analysis. I will show you some examples of early onset complex CMT. The first is this baby that was the first child of consanguineous parents. She arrived some years ago at our observation, age 3 years, with a previous history of hypotonia and psychomotor delay and seizures, and presented with distal and proximal weakness in upper and lower limbs, and presented also associated with intellectual disability. ENG disclosed the sensory motor demyelinating neuropathy, and brain MRI was normal. It was 2012, thus we studied the single genes associated with early onset CMT, considering a sporadic or recessive form, and also an NGS multi-gene targeted panel that resulted normal. Some years later, the parents referred to us the younger third son that presented with similar features in the first stage of life, so psychomotor delay, seizures, and demyelinating neuropathy. We have had the opportunity to verify the evolution of the two siblings. The girl at 14 years of age have developed microcephaly, dysmorphic face. The neuropathy progressed with severe proximal and this weakness. She was wheelchair and developed joint contractures and scoliosis. The boy at 8 years was similarly but less affected. And we then carried out a clinical exome study, which allowed to identify an homozygous mutation in MCM3AP gene that was published by two groups in the same number of brain in 2017 in children with neuropathy, intellectual disability, and variable degree of dysmorphic features. Another example of early onset CMT is, or was this girl, born from consanguineous parents with a bilateral clubfoot and presenting also with very early involvement of upper limbs and proximal weakness and scoliosis and hypovolutism. Were referred to us at 3 years of age. The neurophysiological study showed the presence of axonal sensory motor neuropathy. Then she developed severe feeding problems requiring positioning of gastrostomy, and suddenly she died at the year 4. The clinical exome demonstrated the presence of an homozygous mutation in IGH-MBP2, a gene that was initially several years ago associated with spinal muscular atrophy with respiratory distress phenotype, and subsequently was associated also to axonal CMT2, mostly with onset in first year, in majority of cases, slow progression. These are the histories of two children from two different families sharing similar features. Congenital bilateral clubfoot, walking delay possible only with ankle-foot orthosis, presence of axonal sensory motor neuropathies, and progressive course over years with involvement of upper limbs and also proximal weakness. And in the girl, early evidence of facial weakness. She cannot smile, as you can see in this photograph. And later, she developed also tongue atrophy and acoustic nerve impairment. Both children developed vocal cord paralysis and respiratory impairment. So congenital onset CMT2, and also in these cases, the NGS panel identified two new mutations in TRIM2 gene inherited respectively from their parents. At time of the diagnosis, there were only two previous published papers on two cases with mutation in this gene. One only patient suffered from vocal cord paralysis. And as we know that the vocal cord paralysis has been reported in as a sign of other genes here listed, GDP1, TRPV4, and the others. Then our report showing also the presence of respiratory impairment and the cranial nerves involvement expands the phenotypic spectrum of TRIM2 associated CMT, and confirms the presence of extensive cranial nerves involvement as a core feature of CMT associated with TRIM2 defect. Therefore, these findings should prompt to suspect this type of neuropathy as part of the differential diagnosis. Two other forms are quite frequent in childhood age, that associated to GDAP1 gene that can cause both axonal and demyelinating recessive neuropathy in childhood. The onset for these patients is usually at the age of autonomous walking, around 12-18 months, with frequent falls and clumsy gait. And in the subsequent years, they invariably progress, involving upper limbs and proximal weakness and proximal muscles, leading often to loss of gait and in the second decade. The development of vocal cord palsy is a frequent associated sign during the course of the disease, as I said before. A similar severe progression is observed in children affected with mutations in MFN2 gene. Commonly, the onset is in the first year of age, with a similar progressive phenotype involving distal and proximal lower and upper limbs, and with possible involvement of optic nerve that must be monitoring during the follow-up. This genes shares also common pathogenetic mechanisms involving mitochondrial function in GDP1 about the regulation of fixation mechanisms, and in MFN2 about mitochondrial fusion and axonal transport. Here in this video, you can appreciate this girl affected with the MFN2 mutation, showing the marked disability caused by this neuropathy. Autonomous gait is possible, but markedly impaired with foot throw. The fingers of hands are flexed, and also standing is difficult, as you can see, because of proximal and distal weakness. In this other child, the onset again is in first years with gait difficulties, evidence of distal lower limb weakness and ataxia. At the first examination at 5 years, the nerve conduction study revealed a normal an axonal neuropathy. And the brain MRI showed bilateral alteration in pallidi and dentate nuclei, and then also in cerebellar white matter. This feature, together with their peculiar curled frizzy hair, raised a precise suspicion, confirmed by the genetic studies that disclosed a mutation, a deletion in GAN gene and ultra-rare neuropathy. Then the girl subsequently progressed with marked motor deficit, sensory disturbances, and also development of optic atrophy, severe scoliosis, and cognitive deterioration. In this image, I want just to remember the disease name that derived by the neuropathological hallmark. We don't use more nerve biopsy, of course, for the diagnosis, but the hallmarks are the presence of enlarged giant axons surrounded by abnormally thin myelin sheets. Also, this girl presented since the first years with signs of neuropathy at lower limbs, then progressing on to upper limbs and proximal weakness. She had an axonal sensory motor neuropathy. She has straight hair, brain, normal MRI, normal EEG, and normal IQ. In this girl, NGS study identified also mutation in giant axonal neuropathy gene. That's unexpected, but not unusual because a milder phenotype of GAN-associated disease has been recognized, causing a progressive axonal neuropathy without CNS involvement. I want to present this part of patient to show that in addition to clinical signs, it is essential to deepen the anamnestic data. The boy presented with motor and cognitive delay and show a slow development of distal lower limb atrophy and also pes cavus. At time of first examination, 16 years, we observed dysmorphic facial features. Disclose the presence of optic atrophy and of an axonal sensory motor neuropathy. Upon specific requests, parents reported that he had a lacrimation defect and swallowing difficulties from early infancy. Thus, the first suspicion was an Algrove syndrome characterized by achalasia, lacrimia, and Addison disease. So the genetic studies were addressed on AAS gene, and this growth confirmed the presence of mutation in this gene. And I must say that anamnestic data are crucial also considering the ethnic origin, like in this patient of Romani ancestry, presenting with an early onset axonal motor neuropathy. In the photo, he is not early, but during examination in his follow-up. The neuropathy progressed over years, causing severe atrophy and weakness in distal upper and lower limbs and very severe foot and hands deformities associated with peculiar clinical and electrophysiological neuromyotonic discharges, like this in the image. So we addressed our genetic studies and demonstrated that patients carried a mutation in Hint1 gene that cause both recessive axonal and also HMN neuropathies, and it is particularly diffuse in Southern and Central Eastern European countries. When visiting a patient, thus, we must keep in mind the ethnicity. An example of it is the high prevalence of recessive demyelinating form in Roma Gypsy ethnic population associated with another gene, NDRG1, with the founder homozygous mutation PH 148 stop, as we have identified in these three families presenting with the children with early onset severe demyelinating neuropathy, leading to marked weakness and foot deformities and developing scoliosis, and also deafness, and in some cases mental disability. These are recent studies from the Slovakia group that demonstrated that recessive demyelinating CMT have a high prevalence of mutation in Slovakia in the RG1 and HK1 gene in Roma population. Also, almost the same is shown in the Spanish Gypsy population in these studies. The most frequent form is both in LDG1 and HK1, but mostly in HS3-TC2 gene. But neuropathies due to NDRG1 can occur also in non-Romani patients, like is shown in this case, Raper reporting a woman with motor development delay, that's early onset demyelinating neuropathy associated with sensory neural deafness and showing a progressive course, carrying a novel homozygous framesheet mutation, and confirming that this gene must be considered in the differential diagnosis of recessive demyelinating CMT, independent from the ethnic history. This is the last case I want to present. A boy aged 11 years, born to apparently unrelated parents, normal negative family history, normal psychomotor development, but referring clumsy gait and frequent falls from first years of life. Then he showed progressive gait stiffness with running difficulties, and also weakness in proximal and lower limbs. At 11 years, we examined and observed an unusual association of myopathic and neuropathic signs, including distal atrophy, weakness in proximal and distal muscles, reduced tendon evidence, and evidence of generalized myotonia with slow muscle relaxation after contraction, and also warm-up phenomenon with repeated motor activity. The needle electromyography showed the presence of an increased insertional and spontaneous activity, so consistent with myotonic discharges, and the ENG showed the presence of a mild demyelinating neuropathy. So we thus consider it crucial to examine the asymptomatic parents, and the neurophysiological studies demonstrated the presence of a similar demyelinating, mild demyelinating polyneuropathy in the father, and the presence of mild myotonia in the mother, so raising the suspicion of two concomitant disease. Thus, we performed direct sequencing of CLCN1 gene in the problem that revealed the presence of two pathogenic heterozygous mutation, and also PMP222 analysis that confirmed the presence of the duplication of chromosome 17. We thus demonstrated that one mutation in CLCN1 gene was inherited from the mother, the other from the father, who also carried the PMP22 duplication, thus confirming the presence of two combined rare neuromuscular diseases and recessive Becker congenital myotonia forms and a dominant CMT1A. This case underline that in presence of unusual clinical features and negative family history, we must consider the possible combination of two rare disease, and this has a significant impact on medical care and genetic counseling. Moving forward beyond the clinical cases, I want to spend some words about the differential diagnosis of pure CMT. In pediatric age, we must consider above all the inflammatory neuropathies, although they are rarer than genetic neuropathies. These are several clinical and instrumental features that classically allow to distinguish between the two etiologies, because the onset that is usually acute or subacute in inflammatory forms and slow and slowly progressing in genetic neuropathies. Also, the distribution of weakness that is more often proximal and distal in inflammatory forms, while more often distal in hereditary forms, and also the neurophysiological features that are heterogeneous, that show heterogeneous motor conduction, slow velocities, and often other characteristics like the presence of conduction blocks that are usually not present in the hereditary forms, and also the presence of elevated values of CSF cerebrous protein levels. But nevertheless, it's not always easy to distinguish from the two etiology. As reported in some recent publication, this one describing for children that despite the negative family history and the presence of unusual nerve conduction studies or proximal weakness, and also high level of high protein level in CSF, the final diagnosis was reached through genetic studies disclosing mutations in MPZ or PMP22 and also SH3 TC2 gene. And we finally must remember the possibility of an inflammatory neuropathy overlying on a previously undiagnosed genetic form. Well, once the diagnosis of CMT is done, with or without a specific genetic defect, we must face with the care and treatment. And at present, there is no effective curative therapy for any of the different CMT forms. But it's possible and necessary to arrange and plan the best management. And this is this requires a multidisciplinary management approach with the involvement of several specialists here summarized. The physiotherapist, therapists, and orthotics are a figure of utmost relevance because they can indicate best orthosis, like shoe insert, various ankle foot orthosis, and they can administer stretching and balance exercise. And all of this must be evaluated in every single case by personal expert. Of course, they can be carried out on the basis of the collaboration of the child. These are some examples of, I was saying, this is the girl I previously showed with affected with the MFN2 CMT2 neuropathy. She is working now with shoes, but it doesn't work. Here she tried with short ankle foot orthosis, here with higher ankle foot orthosis, so we can evaluate and decide the better and comfortable. The same can be done with her hand difficulties in writing. And in this video, she's trying different writing grips to choose the better and comfortable. The severity of skeletal deformities, mainly of ankle and foot, often requires a surgical treatment, even in pediatric age, aimed to achieve a stable and well-balanced and possibly pain-free foot. Here are reported the more effective and frequent type of procedures that are those on soft tissues like plantar fascia release or tendon lengthening and tendon transfers, but also procedures on bone, mostly first metatarsal osteotomies and calcaneus osteotomies, while the arthrodesis are generally reserved to patients with fixed and severe deformities. It's extremely important to evaluate timing and decision to perform surgery for each patient, considering not only the age or the severity of deformity, but also, if possible, the expected evaluation of CMT specific form. And moreover, like is suggested by this workshop of the leading experts on CMT, a protocol for a standardized protocol for follow-up should be adopted to allow proper comparison of different surgical techniques and long-term outcomes. Well, coming to the trial readiness, I must say that also in CMT, like in all rare disorders, especially in pediatric age, the trial readiness is crucial to deal with possible therapies that all of us hope come soon, especially for severely progressive CMT. Of course, the earlier the treatment, the best would be the outcome. And an effective trial readiness needs several steps, sharing and gathering case series in order to define natural history of disease, of the single disease, and the development of clinical outcome measures necessary to assess severity and to capture response to treatment that include different outcome measures and also biomarkers. In the past years, a lot of work has been done by the international group of the Inherited Neuropathies Consortium that includes several centers from USA, Australia, and Europe, and also our institute. It was evident that functional measures used for adults, like CMT-NS score, are not suitable for children. Then we contributed with the group to define a pediatric scale, CMT-PED, for children older than 3 years. This is a neurofunctional composite scale that evaluates fine gross motor function, sensation, and balance, and has been demonstrated very useful for evaluate children. So it has been recently translated in several languages. Moreover, studying the relationship between the PEDS and CMT-NS, it was demonstrated that both scales measure the same underlying construct, namely the disability. The CMT-PEDS scale demonstrated also to be suitable and sensible to differentiate different CMT form in childhood, as showed in these two studies in a larger children population, revealing different and worse score in CMT forms other than CMT1A, and also detecting the progression of the disease over time and identifying the most responsive items. CMT PET resulted also useful for the study aimed to identify the most responsive patient subgroup based on the standardized response mean, considering the importance of sample size in planning a trial for rare disease. We concluded that considering a possible 2-year randomized double-blind trial of an intervention for CMT1A, it would require 20 patients per arm, aged 3 to 8 years, and with mild disability level. And using PEDs also in this other study on CMT2A population, we observed that scores significantly increased both over 1 year and over 2 years. And also these data are useful for, again, planning possible trials. The real challenges are little children, the measures for infants and toddlers. Here you can see the completely absence of collaboration in this child that is crying. But after a lot of patients from our physiotherapist and the involvement in play activity, of course, she can gain trust and collaboration. Thus, we have some years ago collaborated to validate a specific measure for infant named CMT Infant Scale for patients under 4 years of age. That is a neurofunctional composite scale that evaluates gross motor function and fine motor function throughout 15 items here depicted. Thus, we have now specific outcome, clinical outcome measure for children early age to adolescence and also transition to adult age. And recently, the baggage of pediatric measure was enriched by the quality of life scale, a patient-reported measure that demonstrated to be valid, reliable, and sensitive for children older than 8 years, and identify 6 domains relevant for quality of life in CMT children. Sorry. Thus, we are quite ready with pediatric functional and parent-reported measure, but not so ready for biomarkers of disease progression. One of these is represented by muscle MRI that can quantify intramuscular fat accumulation occurring as a result of muscle denervation. Muscle MRI has been shown sensitive and useful in CMT1 adult patients, but few work has been done in past years in children. This is the most recent, larger study in 55 CMT children that evaluated the relationship between muscle volume and intramuscular fat accumulation with weakness, disability, impaired gait. And the author demonstrated that the lower muscle volume was significantly associated with reduced dorsiflexion strand, increased disability, impaired gait, profile school, and foot drop. Although I must say that although muscle MRI is a promising, sensitive, reproducible clinical outcome, I must consider that if it can be challenging, difficult for children, for the young children to stay lie still in the MRI for 30, 60 minutes, and even impossible to perform in not corroborative without anesthesia. In addition to clinical and instrumental measures, we need to identify also biomarkers of disease progression that should show less variability and should be more sensitive to detect the changes during possible treatments. And in the last years, many researchers have published on promising blood or other biomarkers, but in majority of cases tested in adult patients. So there is a need to enlarge the studies to pediatric population. Finally, I would like to point up just 1 minute a topic that appears to me very important or rather crucial, the transition process that is not transfers, as all of you well know. Transfers is just a formal handing off from pediatric care to adult health care. True transition is an extended process that begins in early adolescence. So it's necessary to start preparing children, families, and also physicians. And this is a work that should start from the child neurologist, and that certainly require time and should include the team of all specialists involved in the care of CMT pediatric patients. I think that probably all center physicians are trying to organize their best and efficient transition, but they often encounter organizational and administrative barriers that make challenging to realize the guidelines into practice. However, I'm sure that the line between child neurologists and neurologists also in the ARN will lead also this advancement for CMT pediatric care. In conclusion, my take-home message are clinical evaluation, deep anamnestic investigation come first. Pay attention to the sample size of CMT to make an early diagnosis earlier than possible. Also through search and recognizing of associated peculiar features. All patients with the CMT in pediatric age, including CMT1, can develop disability, so ensure multidisciplinary management, including pathways for transition. And I think that continuing and increasing collaboration with other specialists of rare disease through national and international networking, including patient-associated organization, can improve our challenges for CMT management and therapeutic and found therapeutic strategies. Finally, as shown here, all people working in our institute involved in the diagnosis and care of patients with CMT in pediatric and adult department in the neurophysiology and medical genetic unit. And thank you for attention.
Thank you very much, Isabella. Wonderful presentation, very complex topic. I think that I would summarize things by saying that if you don't know much about CMT, it looks all the same. If you know a little about CMT, it looks all different. And the questions that we have on the Q&A, I'm not allowing people to speak because we are a little bit behind schedule. But you have a question from Arabella Akaline. She has a son that is 16, has CMT1A, and since the age of 8, he has epilepsy. You mentioned some relationship between epilepsy and CMT, but what would you comment about the CMT1A being a risk of having increased epilepsy or not?
Well, a big question, but I must say there are no specific CMT pediatric forms that in which we can predict the development of epilepsy. But as I mentioned, some forms associated with central nervous system involvement, such as presence of brain MRI or seizures, we have and we are discovering a lot of complex early onset forms that associate both peripheral neuropathy, mental disability, and epilepsy. So we still not have a flow chart including epilepsy in the science, but possibly in the future with the increasing of knowledge of the genetic genotype-phenotype correlations, possibly it would be included too as a sign.
Thank you. And another question by Dr. Sarkail is as to patients with CMT that he diagnosed the mitochondrial trifunctional protein deficiency. So his question is that if you think that checking metabolic tests would be justified beyond doing whole exome sequencing or other techniques for CMT.
Good topic, because I don't mention the metabolic neuropathies, as I think we must include this form. And as the colleague said, we can find also patients affected with this mitochondrial trifunctional protein gene deficiency, causing CMT2 axonal forms. They are very rare because mostly they develop a metabolic decompensation episodes, and so different clinical signs. But we included this gene in our NGS panel too, and I think that that is necessary to enlarge the panel also to this metabolic etiologies.
And finally, we have a last question about what forms of CMT present more marked deformities of foot in early childhood.
Well, the more severe, so these with the myelinating forms, as I mentioned, those affect, including the mutation in MPZ, EGR2, and PMP22 point mutation for the myelinating form. In the axonal, probably the those with mutations in the IGH-MBP2 and TPRV4 gene. Don't forget in the demyelinating form the NDRG1, the gene that I described in Gypsy Romani patients, because very early and very severe, it is the demyelinating form, very severe foot deformities.
Excellent. So I hope everybody is as happy as I am with this webinar. I think that it's going to be very reviewed for learning much of the things that we've discussed. I would have liked to discuss many more about the rehabilitation, the psychotherapeutic support of these patients, but unfortunately we have to leave this for another webinar, or fortunately. And I would like to end by thanking Isabella for your help and your expertise and the preparation of this very interesting and complex presentation. Thank you very much, and hope to see everybody very soon in one of these places, okay?
Thank you,
Isabella. Ciao.
Thank you, ciao, goodbye.